Thank you, Didier, for the nice introduction. I'd like to thank also the organizing committee for inviting me to speak in such a controversial topic, which is the evolving concept of radioembolization, also described as selective internal radiation therapy, SIRT, in hepatocellular carcinoma. In order to do this, I don't want to start from the beginning, but I'd like to make this story interesting in saying that in 1965, Ariel described a technique for administration of yttrium-90 from the celiac artery, which was subsequently undertaken in 4 patients, and this patient had minimal side effect, although they have a symptomatic, very pronounced improvement. In the late 80s and in the 90s, there was a number of phase 1 trials for what was developed in terms of glass or resin microspheres, 2 products that are still on the market today. And several dose escalation studies demonstrated that safety and the safety and the early efficacy of microsphere in patients with hepatocellular carcinoma, whether or not they had portal vein thrombosis. With respect to the mechanism of action, I'd like to emphasize the fact that chemoembolization on the left deliver a good amount of drug through large size particles combined with the effect of ischemia and hypoxia. Whereas radioembolization on the right provides local high dose of tumor radiation therapy through a much smaller microsphere. They have a very minor embolizing effect. You can see here in one slide of one of our patients resected after being treated with both chemoembolization and radioembolization, the difference of the sphere, the difference of the embolic effect, and the obviously of the size of the particles. Phase 2 studies demonstrated, as I said, efficacy aside from safety. And you can see here median survival ranging from 16 to 20 months, and also showing that portal vein thrombosis was probably the subgroup of patients with the highest benefit from this procedure. And on these premises, on these results, phase 2 trial were the jumping boards for several phase 3 trials that aimed at the evaluation of the overall survival of radioembolization in the advanced stage compared with the standard of care at that time, the sorafenib. And you can see here that surprisingly, all these trials turned out to be negative or halted because of low accrual. The reason for these results are several. There are no time to go into detail, but basically the not correct trial design and also lack of recruitment were the most important reasons for this failure. What is important is that the downstream effect of this was that in the ISO 2018 guideline, the SIRT radioembolization was placed in the negative, I would say strongly negative framework of recommendation with a high level of evidence. But it's also, I like to say that notwithstanding this result, SIRT is still very much used in a lot of subgroup of patients, subgroup populations. So what has happened, and that there is an increased number of studies investigating various positive aspects of radioembolization despite negative recommendation. And you have here one example. This is a legacy study just out in the literature in the next ASCO GI meeting. This is a retrospective single-arm multi-center study conducted in 3 major US centers. Population is from 2014 to 17, and these are child A patients with solitary tumor up to 8 centimeters in size. We can see here 162 patients. You can see the radioembolization achieved an overall response rate of 72%, a 3-year overall survival of 86%, and a duration of response of at least 6 months of 76%. And what also is important that when E290 treatment served as a neoadjuvant therapy for patients undergoing resection or transplantation, the survival jumped to about 93%, while patients not receiving any surgical curative treatment also stayed at very high level of survival, around 83%. And also another important point is that liver function, including albumin and bilirubin, were maintained through the follow-up of the study. A valuable population for CIRT, as I said, is portal vein thrombosis, although with limited extension, not involving, in other words, the main trunk of the portal vein. Patients with non-resectable, non-transplantable ACC with segmental portal vein of tumor origin, of course, with good liver function and normal bilirubin may achieve a survival of about 32 months, a median survival of about 32 months, which is extremely good. And also through this kind of stratification based therefore on bilirubin, extension of portal vein and tumor burden, you may predict who will have a successful radioembolization and therefore identify good candidates for these treatments. Another condition that is important to emphasize is regarding the dosimetry of this radioembolization. In a randomized controlled trial, the personalized dosimetry with the targeting 200 gray in the index lesion was compared to standard dosimetry, 120 plus minus gray in the perfused lobe. And what is interesting here is that the response rate was significantly higher in the personalized dosimetry, with no increase in the toxicity profile, and also with a meaningful improvement, as you can see, in overall survival and progression-free survival. Now, this tells us that personalized dosimetry significantly improve the clinical practice of radioembolization and should be used probably in future trials. And another point is that although the strength of the evidence for radioembolization remains low, with respect, obviously, to conventional pharmacologic-driven studies, you can see that major guidelines start again to reconsider radioembolization as a proposable alternative. You can see here the most recent update of the ESMO, European Society of Medical Oncology guidelines, showing the space for radioembolization in both early and intermediate ACC when I would say conventional assignment is failing or is not feasible. And also you have here a summary of the national guidelines of treatment of ACC in the Eastern countries, showing, for example, how is in Korea or in Taiwan, two countries that have a large amount of experience and rigorous assignment for treatment of ACC, how these two countries consider CIRT as a therapeutic option in almost all stages of the disease according to the BCLC classification. And also, finally, I like to also emphasize that CIRT is an accepted option for hepatocellular carcinoma downstaging. And you can see in this prospective randomized trial showing the benefit of liver transplant in case of successful and sustained response to locoregional treatment in patients with ACC beyond Milan, how CIRT was one of the possible alternatives. And in fact, in this trial, different schemes and combination of the neoadjuvant locoregional therapy was proposed for this kind of patient, including, obviously, radioembolization. Another aspect I'd like to touch it refers to the fact that we have no druggable mutation to target ACC right now, and this has caused a movement of the focus on treatment of ACC to cell-to-cell interaction, particularly immunotherapy and microenvironment. Conscious of the fact that ACC is is defined a cold tumor from an immunological standpoint, as the whole liver is an immunotolerant organ. A cold tumor can be transformed into a hot tumor, both with combination of systemic treatment and also after physical tumor destruction by means of local regional therapy. And in other words, following physical destruction, for example, with radioembolization, we observe an increase in the release of high antigen load from a tumor, an increase in the antigen presentation, and in the level of systemic immunity. And all this creates a fertile soil for immunotherapy, which has become the best treatment strategy nowadays for advanced ACC. Here we have the example of the most effective combination drug in hepatocellular carcinoma, as we will be discussed later on by other speakers, showing that the combination of atezolizumab and bevacizumab may achieve a median survival of 20 months in advanced ACC. The combination of immunotherapy and radioembolization has the same rationale. The immune profile of surgically resected ACC downstage by radioembolization exhibit higher infiltration of CD8 positive T cells, as well as other expression of immune marker listed here. And this finding create the basis for studies combining radioembolization and other local regional therapy together with checkpoint inhibitor. And what is important, not only in advanced ACC, but also in other stage of the disease. The safety of this kind of strategy, of this combination, has already been investigated in Spain. And you can see here the preliminary data from the ILCA Congress, from the NASIR study, combining nivolumab after radioembolization. And you can see here that the overall response rate was up to 40%. And also there was a very favorable safety profile. Quite consequentially, the next step will be the evaluation of radioembolization in the setting of the advanced ACC for the standard of care. And there is also, this is one of these trials will be presented at the next ASCO meeting in combination of atezo-beva plus radioembolization versus radioembolization. This and other trials are being proposed, and you can see here a summary I found in the database of the trials currently open to combination of radioembolization with checkpoint inhibitor. And we may notice that the current trials involving this combination are directed not just to intermediate or advanced ACC, but also in early hepatocellular carcinoma and potentially resectable ACC, so in the neoadjuvant, as the neoadjuvant fashion. Well, it's time to conclude. And these are my conclusions, which summarize also, I would say, my opinion on radioembolization nowadays. This kind of treatment has not gained a positive recommendation in the EASL guidelines, but the result in retrospective is that we set the basis for this use in a wide use worldwide. There is a very important need, which is the identification of the ideal candidate for radioembolization. And for this, we need a biological or a clinical or a physical markers. And there is room here for other development beyond the genome, using new technologies of metabolomics, non-coding RNA, or maybe also artificial intelligence. The use of SIRT is a very valuable option for downstaging strategy. And we know that if this strategy is successful, if downstaging is also sustained, you have the best tool for selection of transplantation and resection beyond the conventional criteria. And finally, we have to work on a combination strategy of this kind of local regional therapy with checkpoint inhibitors. There is a strong rationale for this combination. And as we know that local regional therapies in general and radioembolization in particular increase the tumor antigenic release and favor, in fact, immunotherapeutic strategy. And with this, I'd like to thank you very much for your attention.